So I'd like to acknowledge that we're hosting this session on the unceded and ancestral territory of the Coast Salish peoples. That includes the territories of the Musqueam, Squamish, Tsleil-Waututh nations, and the Métis Charter community of the Lower Mainland region. And you throughout the province are on the unceded territories therein. And I think we've all learned through this last year the importance of caring for the land and respecting the people and the land on which we find ourselves. So thank you for that. Next slide. So today I'm really excited to have Mei-Lin, Allison, and James present to us this QI collaborative project, which is really quite unique. I just want to give our audience a little bit of an overview of who our speakers are, and then I'll hand it over to them. So Dr. Mei-Lin Bissonette is a renal pathologist who joined St. Paul's and the Provincial Renal Pathology Laboratory in 2015. She's currently the director and has been spearheading a number of province-wide initiatives to really improve access, quality, and engagement, if you will, around renal pathology, which is really exciting. Dr. Alison Harris is a clinical professor of radiology at UBC and head of abdominal imaging division at VGH and UBC Hospital. She's also the president of the VMDAS, which most of you know what that stands for, and is past president of the BC Radiological Society. She's the secretary treasurer and on the board of directors of the Canadian Association of Radiologists national executive. And I think her passion and interest in improving quality and collaboration is really evident as part of this project. And Dr. James Nugent is a PGY2 resident in radiology at UBC, did an undergraduate degree at Western and medical school at UBC. And I welcome the three of them to present for us how we're doing and what we're doing to improve renal biopsy quality, quantity, and etc. So over to you guys.
Great. Thank you, Adira. And so we're really pleased to discuss this project this morning. And it truly is a multidisciplinary collaboration between renal pathology, spearheaded by myself, as well as radiology with Dr. Harris and Dr. Nugent. And this project's also part of the PHSA Provincial Quality Improvement Initiative. It's part of Cohort 5, and so we have that support and those resources. And we're really presenting this today, not only to discuss what we've been doing and where we're going, but also hopefully to create a collaboration with nephrology for where we'd like to take this project next. And we all have nothing to disclose. And so hopefully at the end, you'll understand the medical renal biopsy technique and adequacy assessment, and be aware of complications as well as risk factors, and understand the current multi-center approach for renal biopsy in BC and how we do compared to what's in the literature. And also to be familiar with some of the quality updates that we're doing in renal, including adequacy categories and what we're doing in the future with provincial biopsy kits. And so first, it's important that we discuss the purpose of the kidney biopsy. I think we all can appreciate that the biopsy is for diagnosis, but really it's more than just that. We provide the diagnosis, but we're also looking at important classification and prognostic information, and also other important information that can drive treatment, like the extent of activity, the extent of chronicity, where we have important discussions with nephrology for not only what the patient has, but what's in the biopsy for treatment options, how much chronicity, so we can discuss what are the implications for long-term kidney function for the patient. And so it's all very important that it's not just diagnosis. But in order to have this type of comprehensive report, it requires enough cortex and therefore glomeruli for light, immunofluorescence, and electron microscopy evaluation. And so if we need a certain amount of tissue to review in all these different types of microscopy, then the next question is, well, then what's adequate for a renal biopsy? And it's a very simple question, but with a very complex answer, because the biopsy is actually very complex with all the things that we're looking for. And what we need in order to accomplish all of those components of the renal report is dependent on the clinical question. So for example, take IgA nephropathy. So I can make a diagnosis of IgA nephropathy with one glomerulus on immunofluorescence, that really I just need to see the strength and the location of IgA. But with that one glomerulus, I can make a diagnosis, but there's no Oxford classification. So I can't see the morphology on light microscopy to look for important features that have important implications for how the patient will do long-term. And importantly, without enough cortex, I can't look at interstitial fibrosis and tubular atrophy. And so for a lot of different entities, patient prognosis and long-term outcomes is really tied to the amount of interstitial fibrosis and tubular atrophy. But you can't appropriately make that assessment on small specimens, and you need a certain amount of tissue on light microscopy specifically. So with all of this in mind, what happens if it's not adequate? So there's a lot of time, effort, and resources that go into every single renal biopsy. That's true for the patient. Not every patient lives near one of the centers where the biopsy has to be done. It's true for nephrology, radiology, as well as pathology. And so because of all of this that goes into every biopsy, in pathology, we try to provide as much information as possible with whatever tissue we receive. And so for us, that means we reevaluate the tissue between the fixatives, and we can move tissue between the fixatives. We can do additional processing, like we can do immunofluorescence on paraffin fixed tissue. We can do electron microscopy on paraffin fixed tissue. But all of this requires extra time and extra resources because of all the reprocessing involved. And there's a lot of limitations. Like we can take tissue from electron microscopy and review it for light microscopy, but because of the fixatives used, we can't do paraffin immunofluorescence, we can't do immunohistochemistry. There's artifacts and drawbacks to all of this. And so as a result, if we're limited with the tissue and what we can do, we end up with descriptive sign-outs. So a lot of times we will discuss we can't say what is present, but we can say what's not. Like we can say that there's no amyloid, there's no monoclonal deposition disease, but we can't necessarily say what is causing all of the issues. And so this is not ideal nor comprehensive. And so then this brings up the question, so if it's difficult, have people tried to look at this question of adequacy? And to some degree, yes. So specifically, there's some adequacy requirements, but not for diagnosis, but based on classification. So if you look at the original MESC score for the Oxford classification, not MESC-C, the minimum requirement is 8 glomeruli on light microscopy. And so this also brings up the question, now that we also include crescents, is 8 truly appropriate? And the ISN-RPS classification for lupus nephritis, in the original 2004 paper, they suggest 10, but unofficially, majority of renal pathologists really use 20 glomeruli to determine if they really are looking at a focal process or not. Then there's BAMF classification for transplant biopsies. And this is a bit different, that it requires 10 glomeruli by light microscopy. You must have cortex and medulla sampled, and you need at least 2 arteries sampled. And this is because you're looking at being able to evaluate different types of rejection, including vascular rejection, and to differentiate rejection from polyomavirus nephropathy. But then this classification doesn't really get at recurrent disease, de novo GNs, those sorts of issues. So these guidelines are there, but they're not exactly complete. And then this also brings up the question, so in the absence of glomerular findings, so if we're looking at a very focal GN, how many gloms are needed to be confident that there is no focal GN? So take, for instance, FSGS versus minimal change disease. How many gloms do you really need to have to be assured that you're not missing a primary FSGS and you really do have a minimal change disease? Or sometimes things have overlapping issues and it's very difficult. Like take focal posse-immune GN, where we have no findings by light immunofluorescence, no findings by electron microscopy. Often in the background, we get acute interstitial nephritis. So if we have acute interstitial nephritis in the context of a positive MPO, how many gloms do we need to evaluate to be sure that we truly do not have a focal posse-immune GN? And so a few publications have tried to address this, and so this is part of the core curriculum in AJKD in their update in 2019, as well as their most recent update just published online earlier this month. And so both of these tried to get at this question, mostly in native biopsies. And so they acknowledge that the number of glomeruli to make a diagnosis by light microscopy is variable. Like we said, it really depends on the clinical question and what you're trying to show or not show, how focal or diffuse a process it is. And they suggest that 15 to 20 glomeruli sampled are sufficient. But they do acknowledge that for focal lesions involving a small number of glomeruli, 25 glomeruli may be needed for light microscopy to have a more than 95% chance of detecting those lesions. So in the case of like the focal posse-immune GN versus AIN, you really need 25 gloms. But generally speaking, except for these few cases, they say about 8 to 10 glomeruli by light microscopy is sufficient. But again, with all the time, resources that go into these biopsies, it's a balance of having the most comprehensive informative reports for as many patients as possible, but at the same time balancing out the fact that the biopsy is an invasive procedure and does have complications. And so we wanted to look at this for BC, and so our quality initiative has two parts, and these two parts involve radiology as well as pathology. And this is because there's two major aspects to renal biopsies prior to diagnostic review. So the first is collection of the tissue, which focuses on radiology, and there's 13 major sites in BC that do collection, but also some smaller sites that do a smaller number. And once there's the collection of tissue, there's then the assessment and the allocation of that tissue, which is where pathology comes in. So pathology does an assessment of the tissue taken by radiology to give a quantitative, qualitative evaluation of cortex, medulla, glomeruli, so the radiologist can determine how much tissue to take. And once that tissue has been taken, pathology then manages the allocation of that tissue, so the appropriate amount of cortex and glomeruli go into light immunofluorescence and electron microscopy before it's sent to our centralized lab. And so I'll pass it over to Dr. Nugent, who will discuss the radiology component.
Thanks so much, Dr. Bisonette, and thanks so much, everyone, for having us here today. It's an honor to be here, and thanks for your time. We're hoping to get through the presentation in reasonable time, so we have time for a discussion at the end. And I'm just waiting. Oh, I've controlled the slides now. Perfect. So before launching into our survey of radiologists and the specimen adequacy data, I'll just briefly go over the technique for renal biopsy. Basically, before the procedure is done, there's two main things we're looking for. One is to do everything we can to limit the patient's risk of bleeding by checking blood work, making sure they're off the appropriate medications, making sure their blood pressure is low enough, as well as reviewing recent prior imaging to make sure the patient doesn't have hydronephrosis. The patient is also consented by the radiologist before the procedure. And after the procedure, there's a short monitoring period and tissue is sent to the central lab. On the right here, we have a couple images of ultrasound-guided renal biopsies. This is a native kidney seen in its long axis here, and the needle coming into the cortex there. And then this is an allograft kidney seen in its short axis here, and then the needle track coming along into the cortex there. This is just a reminder of the guidelines for discontinuing antiplatelet and anticoagulant medications prior to the procedure. And this is the BC-wide guidelines. You can see that renal core biopsy is considered a high-risk procedure. From a radiology perspective, things to keep in mind is that for a native kidney biopsy, the patient usually has to lie prone for a certain period of time, and that can be challenging for some patients due to pain. as well as difficulties with body habitus, as well as patients with end-stage renal disease. It becomes technically quite challenging as the cortex gets quite thin and it almost camouflages in more with the fat surrounding the kidney. In terms of complications from these procedures, this data is from the literature, it's not from BC, but we see that generally there's a rate of no diagnosis achieved in about 1% of patients, and that a bleed requiring a transfusion or an embolization occurs in about 1 to 2% of patients, with risks for that being low renal function, low platelet count, and having to take more cores or more passes of the needle through the kidney. So before analyzing the specimen adequacy data, we wanted to survey all the radiologists or the department heads of the sites that are performing renal biopsies regularly. And we asked them about how they're currently performing biopsies to get an idea of perhaps reasons why some sites are more successful in their specimen adequacy than others, and see possible interventions that we could implement to improve specimen adequacy rates. And we also assessed their interest and how feasible they thought it was to implement theoretical quality improvement interventions. So these charts here document the radiologist department head responses. So each response is one hospital site. And again, there's 13 hospitals that we surveyed, which are the 13 regularly performing renal biopsies. And we can see the vast majority of procedures are done under ultrasound. Coaxial is a technique that allows a kind of like a needle hub to be left near the renal capsule, so that with each core, you can take the core biopsy out and then insert your needle back through this tract rather than puncturing at the skin every time. We can see that it's used by actually the minority of sites regularly, but it has been shown to increase biopsy speed and increase safety in a randomized control trial. And device automaticity, most devices are semi-automatic. Throw length, that's the length of the core biopsy. Most sites are doing about a 2 centimeter throw. And most sites are using 18 gauge needles. Although interestingly, in the literature, there's a number of sites performing 16 gauge and some sites even perform 14 gauge biopsies. In terms of the shape of the core, this somewhat relates to the diameter of the core. As traditionally, biopsies have kind of this tray that goes along that helps to cut off the end of the core and then pull it back in. There's newer technology that can cut at the end. And by not having that tray, you increase the diameter of your core and thus your tissue. And we can see some sites are using that technology now. And now this is a really important part. Radiologists, if they're lucky, they have a pathology technologist available during the biopsy to take a look at the specimen under a dissecting microscope to see if they're getting cortex, medulla, or perinephric fat. And we can see that most of the radiologists are using the feedback they receive from the technologist to guide how many cores they're taking. But unfortunately, there are 2 sites at this time that don't receive any real-time feedback, and they take usually just a certain number of cores predetermined. In terms of who's performing the biopsies, the vast majority are performed by general radiologists. At academic centers, fellows are performing a number of the biopsies as well, and at some sites, subspecialty trained interventional radiologists are performing the biopsies. Each site on average has about 10 radiologists performing the biopsies. On the left here, the chart shows the feedback that radiologists currently receive from pathology. Less than half state they receive the formal pathology report, and otherwise, radiologists are relying on their friendly neighborhood nephrologist for feedback. Sometimes it's just when a biopsy needs to be repeated as it was non-diagnostic. The feedback that the radiologists are most interested in is having a regular short summary of what the adequacy of their biopsy was. recording and looking at complications is not the central tenet of this project, but it is something we surveyed out of curiosity. We can see out of the 13 sites, only one hospital is recording complications formally at a hospital level. And in terms of being able to handle complications such as a significant bleed that requires a embolization procedure, 4 hospital sites would have to transfer their patient to another hospital to have this procedure performed. Now, these are charts that show feasibility of possible quality improvement interventions from the radiologist perspective. So we have these categories that this intervention is already in place, it's not feasible, it's possibly feasible, or easily feasible and preferred. So basically, we're looking for things that are gray or yellow. We can see that a number of sites already restrict their number of operators, and that it might not be feasible for a number of sites given their practice. There's a bit of a split with whether radiologists are interested in centralizing biopsies to hospital sites. There was some feedback received that in some centers, patients are already traveling a long distance and that it would be unfair for them to have to travel any further for their biopsy. And again, there's 2 sites that do not currently have a technologist present for biopsy. And one of the more popular possible interventions is improving the feedback on adequacy. In terms of the nitty-gritty technique stuff, most sites are already using semi-automatic guns. 16 gauge needles were thought to be quite feasible, as well as the newer end cut core technique. And in terms of increasing the number of core biopsies, there are a number of sites that already state they're kind of at their upper limit of the number of cores they would like to take, but there are some sites that would consider increasing the number of cores if they knew it would improve adequacy. So just before launching into the adequacy data, again, as Dr. Bisonette outlined, there is no standard guideline for this. In terms of what the radiologist is looking at in the biopsy is more whether the technologist says they're getting cortex, and it's kind of an approximation of glomeruli. And the actual formal counting of the number of glomeruli is done later in the pathology lab. Because there's no standard, we came up with this ideally adequate definition, kind of our gold standard, that would allow the patient to get their diagnosis and full classification and prognostic information. So that would be having more than 30 glomeruli. And these were the 4 categories we decided on. We had a category where no diagnosis can be achieved, called inadequate. We had a category suboptimal, where you have fewer than 15 glomeruli, where you can get a diagnosis, but there's no classification or prognosis. And then we had minimally adequate, where you have 15 to 30 gloms, and you can get a diagnosis, sometimes you can get a classification, and then our gold standard as discussed. What was an acceptable target and what would we be happy with? We can see that from the thyroid literature, although this is aspiration data, it's kind of the closest thing to a core biopsy. We can see that they have guidelines stating that non-diagnostic or unsatisfactory should be no more than 10% of the aspirates. And we thought that that was a reasonable target. So we chose that as our first target to have inadequate and suboptimal categories making up less than 10% of our total. Our second target was relating to our gold standard, because really a lot of the impetus behind this project is to improve, for patients getting their full diagnosis, prognosis, classification. And we thought that achieving this in the majority of patients, 75% or more, would be a reasonable target. And before launching the data, I have to thank Dr. Bisonette and her pathology team, as well as the PHSA, Physician Quality Improvement. They retrospectively combed through a huge number of reports over almost a 4-year period across all the hospitals to determine adequacy based on our definitions. So having the number of glomeruli and basically categorizing them. And we can see here, this is a graph that shows adequacy over time from January 2018 through August 2021. We see there's the 4 categories. In blue, we have ideally adequate, orange, minimally adequate, gray, suboptimal, and inadequate in yellow. We can see that there's fairly consistent across time rates. We have ideally adequate and minimally adequate, each hovering around 45% of biopsies. And we have a much lower rate of suboptimal and a lower rate of inadequate biopsies. So how does this compare to the literature? Well, I mean, it's challenging again because there are not set definitions, but we can look to Dalhousie, where they have a somewhat similar setup. They have a central pathology lab that looks over the Atlantic provinces. And they did a QI project where they defined an adequate specimen as more than 12 glomeruli. And in the first phase of their intervention, they actually had an adequacy rate below 40%, but by the end of their project, they achieved 90% adequacy. We're very thankful that in BC, the adequacy rate for both native and transplant combined is at 89.5% for a slightly stricter definition of 15 or more glomeruli. And that corresponds to our minimally adequate and ideally adequate category combined. That's where that comes from. So this breaks it down by hospital site. Hospital sites have been anonymized with a randomly assigned letter, and we have the same colors representing ideally adequate, minimally adequate, suboptimal, and inadequate. And this is for both transplant and native kidneys here. And we can see that the target 1 of having the inadequate and suboptimal, so the yellow and the gray, was achieved by more than half the sites. About 8 of the 13 sites achieved this target 1. Target 2, having the ideally adequate, or the blue, up to 75% of specimens, was almost achieved by 1 site, but it was a long ways off for most of the rest of the sites. Now, specifically focusing on native kidney biopsies, again, target 1 achieved by most sites, and target 2, there's about 4 sites that are within 10–20% of the target, but the rest of the sites are a ways off. So we thought, maybe this target 2 isn't quite right, and it might be a bit too much to ask at times. And at the end of the day, we're trying to find a good balance, and this is still a fluid discussion as to what's going to be best for the patient in terms of the number of glomeruli, but also minimizing the risk of the procedure and not having to take too many cores. So we changed the definition of ideally adequate from greater than 30 glomeruli to 25 or more. And by doing that, we reduced the number required for immunofluorescence and electron microscopy. So here are the updated categories. Sorry to do this to you guys, but we just wanted to show the thought that went behind this. And so this is how things have changed. This used to be 15 to 30 for minimally adequate, and this used to be greater than 30 for ideally adequate. So those are the changes that made. So I'll show you the new data now. And we could see already, you might be able to recognize there's a lot more blue on this slide now. There's a lot more ideally adequate. In fact, about 40% of biopsies previously classified as minimally adequate are now ideally adequate, without sacrificing, per se, diagnostic information, prognosis, and classification for our patients. Again, target 1 hasn't actually changed, but target 2, we now see several sites have already reached target 2, and a number of other sites are within 10 to 20% of this target. And now specifically looking at native kidney biopsies only, target 1 again, and target 2, we see a number of the sites again either reaching this target or within 10 to 20%. There are 3 hospital sites, however, that have struggled and have lower specimen adequacy rates. Now, trying to determine what caused this, we go back to our survey data. And we conducted correlation factors to try and determine if there's a reason for this. This was not a multivariate analysis, but the only factor that reached statistical significance, just despite all those techniques I was talking about, was having the pathology technologist there at the time of biopsy. So those two hospital sites with the lowest rate of adequacy do not have a technologist there. And there's also a couple other factors for these two hospitals that might contribute to their lower specimen adequacy.
Okay, so now we can talk about similar pre-intervention data that was done in pathology. Great, so similar to radiology, we created a pathology survey looking at the operating procedures and some of the background of the technologists. And this one was not distributed necessarily per site, but this was distributed by upper level laboratory medicine management to their general laboratory staff. So rather than answers per site, we've got individual responses. We have 26 individual responses from 10 of the collection sites. And so, as I mentioned, this focused on currency biopsy collection setup, assessment, allocation practices, and again, interest in proposed interventions. And so most of the respondents were technologists. And there's an array of different subspecialty training. Most of the technologists were from anatomic pathology, though some were cytopathologists and some were bone marrow technologists from hematopathology. And in terms of the number of cores taken, it correlates to what Dr. Nugent showed, where a few sites take 3, a few sites take 4, but in most cases, the number of cores taken are guided by adequacy evaluation at the time of biopsy. And we also asked where the location of this assessment occurs, which is important. So for the majority of participants, assessment of adequacy is done at bedside in the radiology suite. However, in several instances, it's done actually in the laboratory and at different time points as well. Some 10 minutes, 20 minutes, some up to 90 minutes, which is important because if that tissue is being taken to the lab for assessment and that assessment is done an hour, hour and a half post collection, that assessment is not getting back to radiology so that they can take additional cores and adjust what's happening. That's collection that's taken and that's it. And we also asked about how adequacy is determined, how the technologists look at the tissue and what they use to determine what is adequate, which is actually, as we've mentioned, a very difficult problem. So many people, and they were allowed to answer with multiple answers. And so for most places, it's a combination of total glomeruli, the total number of cores, the core length, as well as the presence of cortex. But then we look at the confidence in using all of those metrics for determining adequacy, we get a much different story. So in terms of determining presence of glomeruli, most respondents felt very confident in their ability to do so. But in determining the number of glomeruli, you can see that confidence drops quite a bit. And although most people felt confident in determining the presence of glomeruli, determining cortex versus medulla, the cortex being where the glomeruli are all located, doesn't quite correlate. So there's some inconsistencies and definitely differing feelings of confidence with being able to look at these different metrics for how to assess adequacy. And in terms of tissue allocation, how that's also done, because there's the assessment of adequacy, but then how that tissue is distributed. So most people use certain lengths of core within the container. Some use the number of glomeruli per container, and some just try to put a few glomeruli in each, and some it's just 1 core per container. And that's also going to affect what we can do and how we have to transfer that tissue, the artifacts and the timing, etc. And importantly, we also looked at how tissue is prioritized. And so in this case, we had participants rank their choice and then ranked the score. And you can see that in general, the technologists are prioritizing the tissue for immunofluorescence, which is important for us to know because it's actually not our preference. That our preference and our need for what we do is to prioritize light microscopy. And so from our survey, there's pretty variable technologist backgrounds. There's also variable collection and assessment procedures as well as techniques. And importantly, the location of the tissue handling, which probably affects the adequacy rate. And there's also variable confidence in that tissue assessment. And the priority of how the tissue is allocated is also something that needs to be addressed. And the preferred interventions by the technologists involved assessment and allocation training, continuing education with assessment and allocation, and availability of reference resources for difficult cases. And so with all of this together, we put together some proposed first interventions. And so there's two parts to these as well. And the first part is associated with the results from our survey with the pathology technologists. So from our survey, there's a need for more uniformity of assessment and allocation. And we've addressed this by creating a provincial renal biopsy kit, which I'll discuss. And we're going to be performing site visits for each individual site to determine the appropriate next steps that are reasonable for the resources and the issues with each site. And part B is related to the radiologists, specifically getting that feedback back to the radiologists. So we started giving the adequacy feedback within the pathology report starting May of last year. And we copied the radiologist whenever possible with the reports. And we'll also be emailing feedback to the radiology site directors regarding site rates every 3 months. So not individual rates, but just rates for the site. And so here are new provincial renal biopsy kits. These were all distributed to all the different collection sites January this year. It's been implemented by a few sites, and several sites are going under review to see if and how they will implement them. So you can see on the cover, they're all nicely labeled, and it's very easy to package everything up and ship it back to our lab. And we have the 3 fixatives all labeled independently so that there's uniformity in the fixatives used and the containers, the labels, and how they're being received. And we've also included an insert to include the directions with what we have with regarding the 3 different fixatives, as well as some assistance with how to handle the tissue and what specifically we are looking for. You can see here, we have one example of a core with the cortex and the medulla. And what we're looking at from the discussion within our lab is that most of our technologists approximate that about 2 centimeters of cortex will correlate with the ideally adequate category, with a bit of an overshot, but with the general idea of looking for 3 to 5 gloms in immunofluorescence and EM, with the remainder of at least 20 for light microscopy. And in terms of the feedback to radiology, so this is an example of what we've been doing with our reports. So at the end of the microscopic description, we have a note for radiology with the adequacy category and a short summary of anything that would be helpful to explain this category. So in this case, you can see for immunofluorescence, there was 1 glomerulus, no glomeruli for electron microscopy, but that's because the majority were globally sclerosed. And so that's why minimally adequate severe sclerosis of the kidney. And so for future interventions, on the pathology side, we're currently working with the high-level lab medicine administrative staff to arrange for virtual site visits We're going through by health authority, and within each health authority, all the various sites. And so we'll be making our way through the province. And so the purpose of these sites is going to be to determine detailed site procedures, challenges specific to that site, and what available resources or unavailable resources are there, so that we can enable site-specific assistance with whatever that site needs to improve their allocation and assessment. And so we're in talks simultaneously with 2 different health authorities, and we will be collaborating with the first site shortly. And so we'll continue to provide radiology with the reports, and we'll also provide the radiology site directors with quarterly adequacy data. And we're looking to include as many radiologists as possible in the system so that we make sure that everybody gets those copies. And so, of course, with all of this, there raises the question of biopsy complication rate, because we're looking to improve adequacy, and it's important to then look to see if there's any increase in complication rate as well. And as James nicely mentioned, this data is not currently compiled in a systematic way, but we propose working with radiology, so radiology, nephrology, as well as pathology, to look at this issue of biopsy complication rates. And with this working group, we can look at definitions. So exactly which adverse events are we looking at, major, minor, what data do we want to collect and track? They most likely have to be prospective. Retrospective will be very difficult, but also to look at potential methods for doing so. And then we can then compare to published rates. And so, like in summary, there's a lot more to medical renal biopsies than just diagnosis. But looking at what's needed to make all of those important points in the report is quite complex. And so for BC, luckily, all the sites have very few fully inadequate biopsies. And we actually have a reasonable adequacy rate. And there's a lot of sites that are coming up very close to our target of 80%. And there is heterogeneity in biopsy technique. And the only significant factor was the presence of the pathology technologist at the time of the biopsy. And so initially, we have now distributed these provincial renal biopsy kits to support harmonization of tissue assessment and allocation. And pathology, we're going to be continuing with our virtual site visits to see what other potential interventions we can have. And we'll continue the feedback on adequacy to the radiologist via report and also a quarterly summary. And we're really excited and hope for a collaboration with nephrology to help assess biopsy complication rates. And so thank you very much. And if we'll take any questions.
Great, thanks, Maylin and James and Allison. That's a great overview of where we are and where we're going. And I think, I don't know another province that has an initiative like this, where we've had such an interest in making sure the adequacy of the biopsies is from stem to stern, no pun intended. So there are a couple of things in the chat. So I think you've already answered the minimal glomerular number for diagnoses. Anurag's asking, and I think it's reasonable, there are medical directors for each of the health authorities, and would it be possible to include those people in the adequacy data feedback and at your site visits, because it might actually help with garnering discussions and resources? I think that's an excellent point.
Absolutely, I would absolutely welcome that. We're just, right now we're at the stage where we're trying to coordinate what's going on the technical side as well as the professional side. And so we're kind of doing that in combination. So it's not just myself on the renal path side that's working with this. We have a huge technical team that's also assisting. And so they're making arrangements on the technical side, and I will absolutely contact all the site directors. We can work that out.
Great. And they may also have some ideas about how to help you collect the complication data, right?
Absolutely. I'm really hoping for for their assistance in doing that. I think the complication rate, it's something important to look at, but it's going to be complex and difficult to do.
Yeah, I'm just trying to scroll and see who's on. I mean, I think we have had a number of different attempts to try and capture complication rates systematically, prospectively, retrospectively. And I think that's probably something that maybe a small working group of the nephrologists, and maybe some of the fellows would want to sort of sit down and work out how we're going to do that retrospectively before you started this initiative, and then going forward, because I think that was one of the big questions about number of cores required and who gets to say stop, right? Yeah. Other questions? You're welcome to unmute yourself or put up your hand. So Sean is, so yeah, there is for really severe complications, we could actually use PANDA, the hospital, like if people got readmitted and needed coiling or radiology or other intervention, the hospital admission would show that, and because we know the date and the name of all the biopsies, and we can link that with the PHSA database called PANDA, where you get real-time linkage. I don't know how far back it goes, but that is one way to do it. So it's called PANDA, Maylin, and the PHSA Provincial Lab Information System, and others know about how, and it has all MSP and admissions and DAD and stuff like that. So as long as you knew what the code was, you'd be able to link that and anchor it to biopsy. Transfusions, I think, are also coded in MSP billing, so requiring transfusion. Good points, Sean, thank you. Other questions or thoughts that people have? Oh, there's another question in the chat. Have you looked at the impact of trainee or fellow involvement on adequacy? So I guess by operator, is there a difference in terms of adequacy or number of passes of biopsy? Maybe James knows that data.
Yeah, that's an interesting question. So we didn't stratify our data by individual operator, but rather by hospital site. I mean, we do have the adequacy rates for the academic centers, but we don't know what percentage of those are performed by the staff versus the trainee. So yeah, unfortunately, we don't know at this time. It's also, the other caveat to that is that some of the biopsies performed at the academic centers may be in patients that are sicker or more complex at times. And sometimes their biopsy may be more challenging, or if they have, you know, an autoimmune disease that really predisposes to bleeding, like subjectively we see patients with lupus seem to bleed more easily after their biopsies. We may be more or less willing to take more cores in an attempt to avoid a complication there.
Yeah, I think that's a good point. Ron, Dr. Werb has his hand up. Ron, we can unmute you and you can ask it.
Sorry, I was going to do it in the chat. Dr. Nugent, why do we need the PTT?
It's a good question. I'm not certain, to be honest. Yeah,
Invention.
my lab medicine knowledge is failing me at this time. You may be right. It might not be as important as the INR in these patients.
Yeah, I can just quickly jump in there. I think that's a very good point, actually. And I think, you know, for the majority of the patients, you know, we get the INR and the platelet count. At one time, you know, we were giving DDAVP for people with you know, very poor renal function, but I have to admit we've really not been doing that over, you know, probably quite a few years now. I mean, PTT is a good question. I think it seems to be part of the coagulation profile. We're more interested in it probably for the inpatients, to be honest. I think it's less relevant to the outpatients, but you know, I mean, if it adds an additional cost, then, you know, maybe that is something we have to look at.
Yeah, I mean, I think that's the point that everyone's making, is that it isn't, unless the person is on heparin, there's no reason to do the PTT, and it is a cost to the lab, and it might be an interesting thing to sort of delete. And I think most of our protocols do have DDAVP for patients with kidney impairment or other things. And so I think that would be also interesting to look and see how many people are using DDAVP, because that is something that in many of the protocols is standardized. Carolyn Stigant has her hand up too. Carolyn? We'll unmute you in a second. Brenda, can you unmute Carolyn? Trying to?
Yes.
If you want to put it in the chat, Carolyn, that doesn't seem, oh, there you go.
Yeah.
Unmuted.
Can you hear me?
Yes.
Okay, hi. Yeah, thank you so much. I was looking at the your slide on the holding anticoagulation and when to resume anticoagulation. This is a really helpful guideline for us. And locally, our pattern of practice has been considerably stricter on restarting post. And I was wondering if your bleeding data included, like, was that just strictly peri-procedurally, or did that include later bleeds? And if so, did you look at resumption of the anticoagulants?
So the data on bleeding for the biopsies actually came from the literature. It did not come from our study. I'm not sure what their time threshold was for when they stopped looking for post-procedural complications. So I unfortunately we don't know.
Okay.
So just some of that data is available. The NIH is doing a kidney precision medicine project that you may know about, where we're doing biopsies in people with diabetes and hypertension and acute kidney injury who otherwise may not have had a biopsy. So they're getting some of that data, and there are reports available in terms of complication rates, et cetera, in these different hospitalized and non-hospitalized patients in real time with new technology. So that might be something worth looking at, Carolyn, but and they know remote and proximal bleeds.
Yeah,
So,
this is really helpful to have. Thank you.
yeah. Thanks. Other
The question in the chat about if the fellow is listed on the
Yeah.
radiology report. So at least for the pathology reports, we're not able to include trainees in our copy twos. It's the way our system is set up, so we can so we are not able to get copies of the report to the fellows.
but it goes to the radiologist, and on the radiology report, there is a listing of the fellow, at least in Cerner there is. It says who the fellow is and who the staff radiologist is. So I'm wondering whether or not one could do some QI that way as well, because education to fellows who are doing biopsies as to their adequacy might also be something worthwhile. Residents, yeah. Oh, I think there's another question. Hold on. Dan Holmes, INR PTT is bundled in many lab systems, so the major cost is the blood collection itself, not the actual running of the test. Thanks, Dan. So there may not be a cost savings to reducing it, just not ordering it, but be interesting. Thanks. So I think this is a great example of patient-centered quality improvement to ensure that we have the right diagnosis in the right patient at the right time using the right sample. But how much of a village it takes to get that right biopsy is, I think, novel for many. I don't think most of us thought how many people have to be involved to get that right sample. I mean, I think it's very, very sobering for all of us. But thank you for leading the effort, and thank you. We'll stay tuned and hopefully see the impact of some of the implementation pathways that you've started. So really thank you, and thanks all for putting this all together and presenting it in such a cogent way.
Thank you.
Great.
Yeah,
Thanks very much,
everyone.
Great, thanks.